would have been bad. Okay, so here are your objectives. So I have, instead of doing pull up, we're having to switch back and forth. We're going to do old fashioned, all right? So A is one finger. You guys can do this, right? What do you think B is?
3.
We got this. Okay. And you can kind of do it where you don't want people to see. You can kind of just do it like this and then put it up, right? I see people do that. I'm like, I don't want to give the answer away. But it's this. Okay. So go ahead and look at this one. Right, so go ahead and say it. I don't know if I told you guys this when I was a music student. I started out majoring in music, and that was never going to go well, so I switched. But my professor of music theory said, be strong and wrong, instead of being like, right and quiet. So go ahead and say what you think the answer is. Okay, so I'll give you the answer in here. So the correct answer would be B. So we've gone from when I first became a nurse, back in the old days when I became a nurse, we had things like the ADA diet, so the American Diabetic Association diet, and that was where we didn't have any artificial sweeteners, we wanted people to have hardly any carbs. And now what's the diet type that we see? Have you guys been in the hospital yet, anybody? Consistent carb. So it's more about having a consistent amount of carbohydrates and really keeping track of blood glucose and controlling weight. And so you want to have carbohydrates throughout the day and limit alcohol. Carb counting can be done, but it's not as much. It's not as emphasized as much as a healthy diet in general. Okay. Whoops. Okay, so now we're going to go into treatment. So the good news is for type 1 and type 2, the treatment is actually very, very similar. This is just kind of an infographic. So remember that the vast majority of people with diabetes have type 2, so 90% at least. And there's no insulin production at all or extremely little amount in type 1. In type 2, there can actually be too much insulin at first because the body's like trying to help. It's trying to pump out extra insulin, but the body is not sensitive to it. But what can happen eventually, just like anything, is the body can start to get worn out, and then the pancreas can actually have decreased insulin. But for the most part, at the beginning, it's that insulin resistance. Okay, so I want you to just compare. So type 1 is on the left, type 2 is on the right. Sorry, it's a little grainy. It looks really pretty on mine. So healthy eating and meal planning, increased physical activity, and blood sugar checks are on both sides. And then the only difference is for type 2, actually, ideally, people can make lifestyle changes and not need medicine at all, right? For type 1, you're always going to need to have insulin because your body doesn't make any insulin, right? So for type 2, first we would try lifestyle modifications, and then if necessary, typically first oral medications, and if that doesn't work, then eventually insulin. Making sense? Any questions on that? Okay. But even though it's not a weight problem for type 1, you still want to have increased physical activity. Why do you think that is? If somebody's not overweight, why would you really think about healthy eating and increased physical activity? I heard somebody say. Yeah?
Wouldn't it decrease the amount of insulin that's needed if they're exercising and eating healthy?
Exactly, yeah. It helps decrease the amount of insulin needed. Very good. Were you going to say?
How does eating healthy decrease the amount of insulin needed? I know how exercise does.
Yeah, so it doesn't as much. Well, actually, if you're having less carbs and less, then you might need less. But what's the other thing that likes to go hand in hand with diabetes? Heart problems, metabolic syndrome, And so, and then the microvascular complications. And it's just always a good idea to eat healthy anyway, but it does, if you're having less amounts of carbohydrates, then you would need less insulin as well.
And then exercise helps glucose go into the cells.
Yes, it also helps. Exercise also, well, if a person has type 1, though, they can't get into the cells because they don't have insulin. So for type 2, though, it helps insulin get into the cells. Does that make sense? Okay. To make sure I studied up, because you guys asked really good questions. So I did extra prep today, because you guys are, you guys are smart. Okay, so meal planning and dietary management. And I have to tell this story. But when I did primary care, I had to diagnose people with with diabetes type 2 pretty often, partly because of the geographic area I was, and partly just because of our culture. And a lot of times people would get very, very upset. You know, it's a big diagnosis, it's a lifelong thing, and people would get very discouraged. But I had one guy, he wasn't particularly overweight. I think he had a lot of family history, and there are some populations, some ethnicities that have, there's a health disparity where there's an increased risk. And so this gentleman was like, oh no, what do I do? And so I gave my whole spiel, and I'm like a cheerleader, so every time I'm like, we can do this. We can reverse this. You know, most of the time people would be like, chill out, you know, just give me a pill. But this guy was ready to change. And so I told him about the lifestyle modifications, about diet, and he came back to another visit, and he was like, check this out. And he shows me his belt, and it's 2 notches tighter. And he was like, I saw the chocolate cake, and I said, no. Dr. Andrea says no. And I said, I'm not a doctor. And he goes, I don't care. But it was awesome. His numbers went back to pre-diabetic numbers. So he literally went from having the diagnosis to controlling it with lifestyle. So I like to tell that story because I think that we talk about all the stuff we have to do as nurses, but we really, there's actually a study that I read about that was in your book where there was a lifestyle modification group and a metformin group. And both of them had lower rates of, maybe they were pre-diabetic, they had lower rates of diabetes, but it was almost twice as much of a success with lifestyle. So we can't underestimate this enough. This is really important. Okay, so diet, it's not so much about counting carbs, like I said, but it's about really the type of carbohydrates that you have. What do we want to encourage people to have? What kind of? So complex carbs, and those are what kind of foods a lot of the time? Like what kind of breads? Yeah, whole grain. So we want to encourage them to have the majority of their breads and the majority of their carbohydrates either being whole grain or whole foods. And then what does fiber do to help lower blood glucose? Or to help us eat less. Maybe that's a better.
Longer to digest.
Yeah. It decreases, it increases the time that it takes to digest, and that also, I have a tickle in my throat. It also increases satiety, so it makes us feel more full, and so then we're not going to overeat as much. And it also, because remember thinking about how diabetes and metabolic syndrome, do you guys know about metabolic syndrome, right? When I say that? That's like heart disease, high cholesterol, obesity, especially abdominal obesity. And so increasing fiber also helps to decrease cholesterol. So fiber is a good thing. And then for fat, we want to limit saturated fats. To what percent? Do you guys remember from nutrition? What would be the maximum percentage of your fat that you'd want to have from saturated fat? I heard it?
Less than 10%.
Yeah, so less than 10% of total calories from saturated fat. You really don't need saturated fat. You could go just unsaturated. So if you need to have a little bit, and saturated fat comes from what kind of sources? Animal sources, right? So like butter or steak. Okay, and what percentage do we want to have from carbohydrates? Percentage of our calories? 50 to 60%? 20 to 30% from fat? And then 10 to 20% from protein. And then for protein, we want to include some non-animal sources. And the main reason for that is, what kind of fat is in non-animal sources? Unsaturated fat, right? And so it's not so much protein is protein, but the stuff that goes with it, the fat that goes with it matters. And then we also want to decrease or minimize or eliminate alcohol. Do you guys remember what we talked about that a little bit with acidosis a couple weeks ago? So if you have not enough carbohydrates, if people are drinking a lot of alcohol and not getting a lot of carbohydrates, then that can be a problem. But also, more for this part, alcohol competes for absorption and it always wins. So it gets absorbed before nutrients do. Okay? It can also be converted to fat if it's not used, or if it needs to be, if you have too much, it can be stored as triglycerides, and that is also not helpful in diabetes. If people do choose to drink alcohol, it's good to take it with food. And that would be a balanced meal. And try to have low carbohydrate types of alcohol. And then what do you guys think is the amount for moderate alcohol intake for women? How many drinks per day? What do you think? It's 1 drink or less per day. And then for men, 2 or less a day. So it's also important to ask, don't just tell your patients, don't have too much alcohol. Like, actually ask, and there's ways to say it where it doesn't sound judgy, like how many drinks would you say you have a day instead of do you drink, right? Sounds a little bit less judgy. Okay. Any questions on the nutrition part? Yes.
For alcohol, are those recommendations specific to diabetes?
Yes. I mean, it's a good recommendation in general, but especially with diabetes. But yeah, I think that's the definition of moderate is the same though for anybody. Yeah. And I think that's not what people think of when they think moderate, right? So I'm not a cynic. I believe people, but they say, double the amount of alcohol. People say, I try not to do that because I try to ask, but people might underreport for lots of reasons, right? They might think that it's not socially acceptable. They might worry about what you think about them. Maybe they're not really keeping track of it, So that wasn't good. Okay. Any other questions on nutrition? Okay, so exercise. So exercise, as we already talked about, helps to decrease the need for insulin, and it also helps to increase sensitivity to insulin. So for people that have that type 2 diabetes, it can decrease that insulin it can increase the sensitivity, which is good. And so there are guidelines, and this is really really relevant, especially for type 1 diabetes. If somebody has their blood glucose level is less than 100 before a workout, it's not safe to exercise, even though their blood glucose is in the normal amount. Remember, exercise is going to make that go down, and so we don't want to have a hypoglycemic episode. And so it's advised to have a snack of carbohydrates before working out, so 15 to 30 grams. If people are in that range of 100 to 250, it's considered safe to exercise. One thing I want you to think about, none of this is absolute. Anybody who has diabetes, does anybody know anybody that has type 1 diabetes? Okay, so you probably, if you talk to this person, there's going to be a different personalized plan for every single person. So it's really important for the person to communicate with their provider for their plan. So this is just the guidelines. So it doesn't mean it's going to be exactly the same for everybody. If somebody has a blood glucose of greater than 250, it might not be safe to exercise. And so the person needs to check their urine for ketones, because that would show that they don't have enough insulin, and so there's increased risk of DKA. And so first they would need to drink some fluids, keep checking their blood sugar until it's below that 250 and there's not ketones. Make sense? But especially for type 2, when there's not that risk of DKA as much, because it's a lot more common in type 1, We need to encourage people to exercise. So moderate intensity, more days than not. So like 4 days out of the week, try to do some moderate intensity exercise. Not just a slow walk, but something that gets your heart rate up. Okay? And I will say, some people get sick of hearing that, but we have to keep saying it. I had another patient, not the same guy that thought that I was wonderful. Another guy was like, "You're just going to tell me to eat vegetables again." And I said, "Yes, I am." And then I just gave my speech again. So it's good to just keep encouraging. All right, another pre-test question. And pre-test means I know we haven't talked about it yet. It's just gauging kind of where we're at. Okay. Go ahead and raise them up. I see a lot of ones. Good. So metformin is kind of the standard of care. Even for prediabetes, a lot of times people will be started on metformin. We'll talk about it more in a little bit. And then insulin are the other choices. That would be for type 1. Okay, so remember, so oral agents are going to be for type 2. There can be a lot of drug-drug interactions, and there can be a lot of side effects. I'm going to highlight the main classes of meds that I want you to really know about. But some major side effects for the majority of them are hypoglycemia and liver damage. So those are kind of the big picture things. And now we're going to talk about some specific ones. So there's 3 different classes that have major or life-threatening side effects. So metformin is a wonderful drug. It's a biguanide, but it does have, does anybody know that major, take off the cobwebs from farm, make Stephanie proud. Do you remember what the major life-threatening side effect is from metformin? Yes. Yes. So it is a very complex process, and I'm going to just break it down, okay? So it's lactic acidosis, which is a type of metabolic acidosis, and it can be life-threatening, but especially combined with a renal insufficiency or renal failure, okay? So that's really as far as you need to go for the test. It's not very common, but you need to think about renal function before giving metformin. And I listened to a guy that does some really good mnemonics, and he said metformin, you capitalize the M, and that's metabolic acidosis, and lactic acidosis is a type of metabolic acidosis. That's a good way to remember that. I actually had a patient who had a major complication after being given, I think, even just a single dose of metformin. He'd been taking metformin for a while, so it wasn't because it was a new medicine. Can anybody think of maybe what happened in combination of taking that metformin? Thank God I didn't give that. I took care of him before and after, and I was like, did I do this? It wasn't me, thankfully. But can you think of something that would be a really bad combination with metformin? What is it? Can you say it louder? Close. Dye. Just take off the rhetoric. So contrast dye. I'm going to give it partial credit, guys. She said dye. I'm learning this thing. It said to wait an uncomfortably long amount of time before you give the answer, because it makes people that might not usually speak raise their hand. So it's very awkward for me, but I'm trying it. It also makes if you're not going to answer it, your wheels are turning, right? So contrast dye and metformin is not okay. And that's because contrast dye can cause renal problems, because it's hard on the kidneys, it's excreted through the kidneys, And think about if somebody's going to have contrast dye, something else is happening in their body to make them need that, right? And so do you guys remember how long you should wait after being given metformin, or sorry, after getting on contrast dye before you should restart metformin? 48 hours. So you're also ideally supposed to hold it before, but if somebody's in the ER and they need a CT scan, you need that contrast. Sometimes you have to do it without waiting. And so a lot of times they'll give some IV fluid to kind of flush the kidneys out before and after as well. So the patient I'm talking about got some metformin after a CT scan, and he had full renal failure, like Pillsbury Doughboy. He actually had to have emergent, it's when you're too sick to have dialysis, there's something called central venous hemo. Yeah, but it's another word at the end of it. But it's like where it's like 24 hours. It's taking off a small amount of fluid constantly. It takes 2 nurses to take care of the patient at once because it's too hard on their body to do regular dialysis. So he was very, very sick. And that's just because of that combination. So there's your scary story with Andrea for today, and that's a real one. So just remember, contrast dye, you always have to check before giving that. TZDs, I'm going to try to pronounce it for you. I practiced it. Thiazolidinedionines. I said that, and I'm recorded. TZDs. The major side effect with TZDs is heart failure or myocardial infarction. So just think cardiac. And I'm going to talk about these different classes in more detail in just a minute. And then glucagon-like peptide 1 agonists or GLP-1 agonists can cause pancreatitis. So these are the 3 that are kind of specific, unique, major side effects. So I just thought it'd be good to kind of keep those fresh in your mind. And now we'll talk about, I'm going to focus on a few particular classes that I think are most common for you to give, okay? And just classes, not individual medications. Is that good? Okay, so the first one, we already talked about metformin. And what does metformin do? So this is from your book. I just thought we'd break this down a little bit. So it decreases, so here's our liver here. It decreases hepatic gluconeogenesis. And so that's the fancy word for hepatic glucose output, right? So metformin really works in the liver. Just because you might see either term used, okay? So glucose output, gluconeogenesis. And it also increases peripheral glucose uptake. And remember I said it increases insulin sensitivity? That's kind of what that means, right? So if the cells are more sensitive to insulin, then they're going to be able to take cells up. So increased insulin sensitivity. Leads to increased peripheral glucose uptake. So I talked about the life-threatening risk factor for metformin. Can you guys think of kind of the non-life-threatening ones that might still make somebody not want to take it? This is a medicine you're probably going to give, I'm going to go ahead and say, I'm going to give an estimate here. You're probably going to give it at least 1,000 times in your career. Oh, did Kathy leave? I was going to ask for her to estimate. You give it all the time. So it's a very, very common medicine, so you need to know it. Yes. GI upset. So nausea, vomiting, and diarrhea. So this is a major reason that people might not keep taking it, as you can imagine, right? The good thing is if it's titrated slowly, then that side effect can be minimized a little bit. So it's good to start it low, take it with food, and then gradually increase it. Okay. You always want to monitor renal function because of all the reasons I said, because it can be hard on the kidneys. Yes?
With metformin, because of the lactic acidosis, does it cause like muscle aches too?
Not in general. And lactic acidosis, it is a serious side effect, but it's very rare. Yeah. So it could happen. I haven't heard of that side effect. At least it's not very common if it is. So I'm not going to promise, but nothing I've heard of. Okay. Are we good on metformin? You got to know this one, okay? And Carrie and I made a beautiful piece of art that I'll show you in a little bit to help illustrate metformin for you. Carrie's the artist. I'm the brains. Well, I'm some brains at least. Okay. So the next one, which I'm just going to touch on really briefly because you might see it, but it's not recommended as much as it used to be because now we have new medicines. So sulfonylureas. So there's only one biguanide, okay, and that's metformin. Sulfonylureas is a class and they work on the pancreas to increase insulin release. So what do you think would happen if that is taken and somebody doesn't eat? Yeah, so severe hypoglycemia can happen. Even if they do eat, maybe they don't eat enough or they take too much of their medicine. So this is why this is not prescribed nearly as much as it used to be. And I don't know if I said this in my video, but Simple Nursing, guys have all probably seen that, right? The guy, Mike Linares, he has videos. Hypogly, the brain will die. So like hypoglycemia is a really serious thing. Okay. And the way that I remember these is they end in "ide." So that, and an example of that would be glipizide. There's also glyburide, but they end in "ide." Okay? So important to know that one because if you have somebody that say they take it at home, they're at risk for hypoglycemia. So some newer medicines that don't have as much of that side effect are, there's two that are related, so I'm going to talk about them kind of together. And they are the DPP4 inhibitors and the GLP-1 agonists. Okay, so I know this sounds confusing, but I'm going to break this down. Okay, so after you eat, there's hormones in your intestines called incretins. And basically, when our body is working normally, then hormones are released that help with digestion and help with hormonal regulation. So the GLP-1 is one of these incretins. So if you just think about what an agonist is, that's going to mean that it helps these hormones to work better or to be more present. So just on the opposite side of the coin, a DPP4 inhibitor, DPP4 is what inactivates the incretins. Okay? So if you block the thing that blocks it, that stops the chain, then it helps the incretins to keep working. Does that make sense? So you wouldn't get both of these together because they do a very similar thing, okay? So that's why I'm gonna kind of talk about them together. So incretins are released from the intestines. They increase satiety. So help you feel full and satisfied, and they slow gastric emptying. And in our bodies, when these hormones are working correctly, that helps us to, it's our signal to our body that it's time to stop eating, right? So that can help with weight. So if the DPP4 inhibitor keeps those incretins working, then you're going to have increased satiety, and it also helps to increase the amount of insulin. But it's in response to eating. So not as much of a risk of hypoglycemia, because you're not going to get that hormone bump if there's not food intake. Yeah.
So what's the role of the DPP4? I was a little confused.
It is what inhibits or kind of stops the GLP-1 agonists from being secreted.
But don't the agonists increase the incretins?
So the DPP4s stop the incretins from being released.
So then you're not as full and you have quicker gastric emptying? Because if you're stopping the incretins.
Yeah. One thing that happens with obesity and with diabetes, more with obesity, is those hormonal signals are not interpreted correctly in the body. And that's kind of beyond what we need to think about. But the big thing is that if you block the inhibitor, so like the off switch, then the incretins are able to keep being released. So I would say the DPP4 is the off switch for the incretins.
And then why don't we want more of those to keep to be like fuller? Why are they add them?
You do want them. So DPP4 is the, I can point on here. So if you don't have the off switch, then these can keep working. So this type of medicine helps the GLP-1 to stay active. Or you could take the GLP-1 agonist, and that's to make those hormones be released more.
So did you say give those together or don't give them
No,
together?
because they do a lot of the same thing. Yes?
So what we've talked about so far, does that apply to both types of medication, or is any of that specific to one or the other?
So far to both. Yeah. Yes? It doesn't, because it's in response to eating.
Oh, so it's like naturally.
Yeah, so it increases insulin release, but it's not, like the sulfonylurea it's just making the pancreas pump out more. This is really just keeping the incretins from being inactivated. So it's just letting them,
Will activate insulin release?
yeah,
Okay.
but in response to eating. So less of a chance of hypoglycemia. So the major difference between these two is that GLP-1s, the GLP-1 agonists, are the ones that can cause pancreatitis. We don't see that as much. We don't see that with the DPP-4 inhibitors. So a lot of oral antidiabetic agents and insulin actually can cause weight gain. Another good thing about these two medicines is they don't cause weight gain. And that makes sense too, right? Because if you're feeling more full when you eat, are you going to eat more? No. So it doesn't cause weight loss so much, but it helps to not have weight gain. And we are going to have an activity in a little bit that can help to look at these a little more closely as well. Another thing about the GLP-1s is they are an injection, so that can be something where sometimes people are not a big fan of that. But if you think about it, the next step might be insulin. And so actually my stepdad was on one of these medicines, and it caused so much decreased satiety that he actually had gastroparesis and had vomiting and nausea like last week. So it was weird to talk about it today. And it's a once a week shot. So that was an effect that lasted for a while. Okay. So the next type, so the DPP4s and GLP-1s, like I said, they're kind of related. And the next type is the and I'm not making you learn what these stand for, because a lot of providers couldn't even say what I can read it to you. It's dipeptidyl peptidase 4. So it's a lot easier to say DPP4. Okay, so SGLT2 inhibitors. And these are all in a table in your book. So don't feel like you need to write down every single thing. I'm just trying to kind of talk them through. And these are the flozins. So an example of that would be gliflozin. And this actually works in the kidneys, and it helps block the reabsorption of glucose by the kidneys. So it increases glucose excretion in the urine. So it literally just has the body get rid of glucose through the urine. Side effect of that, what's something that really likes sugar? Bacteria love sugar. So if you have a lot of sugar that's being eliminated through the urinary tract, increased risk of UTIs or yeast infections. And this can cause hypoglycemia because it's not dependent on food intake, right?
Because it's not what?
It's not related to food. So it's going to make the kidneys excrete glucose regardless of how much the person is eating. And this one just makes me laugh because flozin, urine, it just works, right? Flow. Okay. And last one. Is the glucagon-like peptides, and those are the actually I talked about that already. Glucagon-like peptide is the GLP-1, and so that would be the tides. Okay. All right. So we will have an activity in just a little bit where we're going to look more at these medicines, okay? Let me see. My stuff is blending together. Let me see if I can fix this so it won't bleed into each other. Oh, yes, I'm sorry. Yeah, the TZDs. Thank you. I'm irritated by my... Okay, so the TZDs, thank you. Those are the glitazones. And these increase insulin sensitivity. It's a complex process. I'm not gonna test you on this part, but if you were like, I need to know how, it binds to a nuclear factor that's called peroxisome proliferator activated receptor gamma. And I would never test you on that part, but just the effect of it is that it increases insulin sensitivity, which sounds like a great thing, but because of those cardiac, potentially life-threatening risk factors like heart failure, they're not prescribed very often. But again, kind of like sulfonylureas, it's good to know those major side effects. Thank you for pointing that out. This is supposed to be down. I'm sorry.
Are you not going over the guidelines?
What's that? Okay. So the nurse should intervene immediately if a patient has which blood glucose level? Sorry, D should be on the bottom. Four. So 80 to 150, 80 to like 180, especially after eating, could be considered kind of normal because you have that postprandial spike. 200 is high, but it's not high enough that you're going to have like a serious effect. But 40 is severe. And remember, hypogly, the brain will die. So that's like a medical emergency that you need to take care of. So hypoglycemia and hyperglycemia. Hyperglycemia, we'll talk more about the severe types, so DKA and HHS. But in general, a lot of these are just the symptoms of diabetes, right? So increased thirst and frequent urination, that can happen, that's one of the signs of diabetes, right? The 3 Ps. There's also a dry mouth, there can be blurred vision, and weakness. Hyperglycemia, unless it's DKA or HHS, is not really a life-threatening thing. It's something that we need to take care of, but really, if you're in doubt if somebody has low or high blood sugar, you're going to always treat them like it's low because that's such an emergency. And sometimes you can't tell, like these are like if it's like really straightforward, but some people will have different manifestations than others. But sweating or pallor, irritability or hunger, those can all be signs of hypoglycemia. The most dangerous one is when somebody is really sleepy or non-responsive. And so one thing we need to teach patients about is really what the signs are of hypoglycemia so that they can intervene and know what to do, because some people are less sensitive to it than others. Okay, so insulin, I'm just going to talk about the big picture stuff. So in general, there's peaks to all the different types. There is rapid acting, regular, intermediate, and long acting. Your book has it. I'm going to give you the exact times for your books because I don't want to contradict that. So rapid can start to work. This one says actually within 5 to 10 minutes. Your book says 30 to 60 minutes, but just a really rapid onset.
You want us to know the book stuff for the test?
Yes. But I do think it's good to know that for some people it works, really, really fast. And then, actually that's the peak. That's actually in there. So this peak is a little bit longer, 30 to 90. Your book says 30 to 60, but I have heard it from, around an hour to an hour and a half. So as early as 30, as long as 90. Big thing for that is if you're going to give a rapid acting insulin, you need to make sure that they're going to eat really soon after it or they're going to have hypoglycemia. So that's why on here I have peaks need plates. So anytime that any of these have a peak, the person should be eating. So for rapid, it's 30 to 60 minutes. And examples of those would be Humalog or Novolog. Brand names are Lispro or Aspart. I care a lot more about the classes than I do about the names because I feel like you can always look up a name, but you need to understand how the classes work. Okay, short, there's only one type. That's regular insulin. And that peaks in 2.5 hours about, and this one says 2 to 5. And it works for 4 to 6 hours. So if somebody has short acting, you need to make sure they're eating around 2 hours after, right? So if you give that, or sometimes, so you could give it a little bit before the meal, but for rapid, a lot of times it'll say, give them food within 10 minutes of giving the insulin. So I just like to think about at least, having something that they're eating at that time. And then intermediate acting is NPH. One way that I heard about that is not particularly hasty, because it's a little bit longer. And that is a tricky one because its peak can be anywhere from 4 to 12 hours. So this is when it gives some nice longer control, but you need to make sure that people are eating regularly for that. And then long acting doesn't peak at all. So that's Lantus would be like the brand name for the long acting, or Levemir. And that is one where it lasts for 24 hours, sometimes even up to 36 hours. And so it doesn't have a peak, but it's important to take it at the same time every day so it doesn't get that double up. If somebody has really severe diabetes, they might even take Lantus twice a day, just to make sure they don't have any drop. Okay, so peaks need plates, so make sure that you know those peaks. So for rapid acting, I have on here, should have food in front of their face. Regular insulin is the only type that can go into an IV. So if somebody needs like if somebody has DKA or HHS and they need insulin IV, that's always going to be regular. Or if somebody's on an insulin drip, that's always regular. And then intermediate is cloudy. If it's mixed with another type of insulin, like a long-acting, it goes in second. And then the long-acting glargine has no peak. This is just a picture that kind of shows how, this is how the normal pancreas responds. So there's a spike with meals, and usually dinner is the biggest meal of the day, so that's why there's the biggest spike. And so if somebody has 2 injections a day and NPH, the NPH is really that basal insulin to kind of keep the blood sugar down all the time. And then rapid would be given with meals to cover that spike. So see how it's trying to kind of mimic what the pancreas does? If somebody has 3 to 4 injections a day, it's looking more and more like that normal pancreas. And this is kind of cool too. If somebody has an insulin pump, it can be, they have their basal that goes all the time, so it's a small amount that's going 24 hours a day, and then they're able to give themselves that rapid acting bolus with meals. So complications of insulin therapy, it's not very common, but there can be local allergic reactions. Even more uncommon to have systemic allergic reactions. With the use of human insulin, that's really cut down on those reactions. And it's cut down on the lipodystrophy as well. And that's where there can be like puckering of the skin or some cosmetic irregularities. People can develop resistance to insulin. And then there are people can have morning hyperglycemia. You guys remember these from a long time ago from patho, the Dawn or Samoji. And the big picture is that in the morning, so the Samoji is like rebound, where if somebody got too much insulin at night, what is our body going to do? It's going to try to help by giving, by putting out more glucose, and that's going to result in that rebound. And then the Dawn, I think this is my theory, I think our bodies know it's time to get going. We need to have some energy for the day, and so their blood sugar levels in the morning tend to be higher. And so it's just people need to kind of check their blood sugar and get to know their body and notice those trends so they can target their insulin. For temporary increases in blood glucose, higher blood glucose levels are seen if people have stress, if they're on steroids, if they are sick, or if they skip insulin dosages. We'll talk a little bit more about sickness on Thursday because it really ties in with DKA, because the number one cause of DKA is infection. And so people need to have a really strong plan with their provider about how to respond if they're feeling ill. So we'll talk more about that day. But it's not uncommon. Think about anybody who's in the hospital. Are they at risk for being stressed? I would say. One second, then I'll tell you. And so it's not uncommon for people with type 2 diabetes to need insulin while they're in the hospital because of that stress response. And you have to tell people it doesn't mean this is forever. It doesn't mean that you have to be on these shots. Yeah, go ahead.
So during like heat waves, I know that people with like type 1 diabetes have to like worry about like DKA. Is that because the heat messes up with like the insulin, or is it because?
I don't really know. I haven't really heard that. Now I have to look it up.
Okay.
I don't know.
I know my cousin was like in the hospital
Okay.
during the big heat wave.
Maybe they,
DKA, and
yeah. Dehydration, maybe, but that's not really a main cause of it. We'll talk about it more on Thursday, but I'll look it up, and if you can look it up too, we'll compare notes. Okay. Does this make sense, though, for the things that would cause a temporary increase? Steroids, even if somebody isn't diabetic, they'll have an elevated blood glucose while they're on steroids. Okay? So hypoglycemia, what do we do about it? And actually, I have a little handout for this. Can I get a couple? I made 30 copies, so it's to look at with a partner. But I'll talk about it while they're handed out. So the big picture is if somebody's conscious, first off, that's not quite as severe, but it's still scary, right? We can give them something PO. Please do not give anything PO to somebody who's unconscious. That's not good, right? So if somebody's conscious, what kind of glucose do you think you're going to give them? Don't look at the second page. That's for later. What kind of glucose do you think you're going to give somebody? Let's say their blood glucose is like 50. Okay, can we listen, please? Hello? So we want to give a fast-acting type of glucose, so a simple carbohydrate like juice. Not sweetened, it's already got the sweetener, so 100% juice works, but it's that simple sugar that's going to get absorbed really, really quickly. And so you want to give a simple sugar, PO. Okay, and then when do you think you want to reassess if somebody has low blood glucose? 15 minutes. And then if they're unconscious, like I said, please don't give anything. There's two different things you can give somebody who is unconscious and they have a low blood glucose. I think I heard dextrose. So D50. So dextrose 50%. IV, or there's one thing you can give IM or even sub-Q. Yes. I've heard that glucagon makes people feel really nauseated, so just be aware of that. And you're still going to reassess, I would say, at 15 minutes at the longest, maybe even sooner if they're not conscious. You would not want to leave that person, right? They're because the brain really needs sugar, right? Yes.
Do you see like the effects happen instantly when pushing the dextrose 50, or does it take like a couple minutes?
So your book says several minutes. Yes, I have seen it happen really, really quickly.
Okay.
Yeah. I had a patient, I got to go on a paramedic run, and a person was having a seizure, and they were unconscious, and their blood sugar was like 15. And I was like, I never want to be a paramedic. I don't have a team. And they had an insulin pump. And so I got gold star because I turned off the pump, even though it's like a tiny amount every hour. But you want to stop the insulin pump. And then we gave D50, and they woke up pretty quickly. Glucagon takes a little bit longer because it's IM or sub-Q, so that can take more like half an hour. So you still want to reassess. Like I said, 15 minutes to me is a long time if somebody's unconscious, but that's like to recheck their blood glucose. So let's say, looking at your sheet here, this is a real order set. Do you see that I'm the doctor? I put Dr. McDreamy was this provider. And so let's say the person had a blood glucose of 40 and they were awake. Do you guys see that on the bottom? Hypoglycemia protocol. I don't like giving graham crackers or milk because milk also has fat and that can make it not be absorbed as quick. Juice is really, it's my favorite. Glucose tabs are good too, but people like to drink juice, you know. Okay, so let's say it was 40. What are you going to give? Some juice. And then let's say that after that it is 70. What are you going to do? You recheck in 15 minutes. So you would want to get it above 80, and then what do you want to do after you get it above 80? It's not on here, but I want you to think about it. What's going to happen? You only gave a short-acting sugar, right? What do you need to give them? Give them a meal. Yeah, so give them a lot, more of a real meal that's going to be absorbed more slowly, so they don't have that crash again. And then you want to recheck them again. So this one says an hour, but you know, keep checking them because it could happen again. Okay? So let's say it was 40 and they're unconscious. This is 25 mLs of D50 and notify the physician. And then again, if it's too low, then you would either need to repeat, and really then they might need to have a higher level of care. You know, if they're just not coming around, they're not conscious, because that brain needs glucose. It can't use other forms of energy. Okay? So next step would be repeat either one, and then after 80, give a meal. Make sense? Okay.
Can you go back to the?
Yeah. Okay, so key education for a patient, they should see their primary care provider every 3 months to have their A1C checked, and then monofilament is to check their feet. So that's part of that diabetes every 3-month visit where they check sensation. And they should have a lipid panel every year. I hate feet, so this next slide is pretty much the hardest thing for the entire year for me. I'm going to show you pictures. You want to tell them to report infections or wounds or any neuropathy, and then also get regular eye exams because there can be retinal damage from diabetic retinopathy, so retinal damage from diabetes. Oh boy. So this is, I made this mnemonic up. I think I did. Inspect the feet daily for changes. Moisturize, but not between the toes. See a podiatrist for corn removal or also for cutting the toenails. And toenails should be cut straight across so you don't get ingrown toenails. Wear real leather shoes because they breathe better and they tend to stretch a little bit more and conform to the feet. They should wear orthopedic shoes that are well-fitting so they don't have blisters, because if you wear shoes that are too big, that's when you can get those blisters. And they should not walk around barefoot. Verify any new findings right away, so don't wait. Call the doctor right away if they see anything going on. And every day wash their feet with mild soap and water. Oh, that covered up, sorry. Dry feet well in between the toes, so dry between the toes, because you don't want moisture to collect between the toes. And then socks should be clean, cotton, and not too tight. And if you don't do all that, you can have things like this happen where it has to be amputations or really complex wound therapy. I think we're just about to. So let's take. All right. Okay. This is the fun part. So this is where we get to kind of put this into practice. Okay, so this is a short one. Case study. Just a quick one we're going to do together. A patient with type 1 diabetes. What am I not saying? And I'm not perfect, but I'm not saying a diabetic, right? A person with diabetes. Just trying to reinforce that language. He got 24 units of NPH he gets it at 7:30. When does that peak? Do you guys remember? This is that one that's kind of tricky because it has a long range. I don't want to give it away, sorry. Yes. So that is a long range, right? I think I skipped a. He refuses his dinner. So what would be the nurse's priority? What time? So if he got, oh wait. Okay, so let's say that dinner is like at 5:30. And he got it at 7:30. It still might not have peaked, right? So what would be your priority if you were a patient's nurse and they were like, I'm not going to eat tonight?
Recheck their blood sugar.
Exactly. And then what if it was low?
Just snack.
What if he's like, I'm just not hungry? So yeah, see if they can have something, and if they refuse, I would offer, how about just a little bit of juice, like 4 ounces, right? But they might need, it doesn't always have to be D50 if it's not an emergency, right? It could be a little bit of glucose even in an IV. So it's not that, because you don't want to have that crash after. Okay. And then let's say it's normal at 5:30. Are we like, oh, you're fine. It's not low? Because until 7:30, it could still be peaking, right? And so you have to keep an eye on it. The worst is when somebody mixes up their insulin and they take way too much of a long-acting, because then you have to keep reaching. There's not a peak, and it's going to work for 24 hours. So that is when it gets more complicated, right? Because then you need to, you can't just wait for it to wear off because it's a long-acting one. Okay, type 2, 39-year-old female. Her BMI is 31, which puts her in the category of obese, so 30 or higher, right? History of high blood pressure. She's seen at urgent care. Her blood pressure is a little bit high, right? Her random blood glucose is 225, and she's advised to see her primary care provider for a follow-up. So does she have diabetes? You have to have 2 readings. So it could be that she had a really big Coke and she was really stressed, right? So it's looking like it, but you can't confirm it because it's 1 reading. What tests at follow-up would confirm a diagnosis of diabetes?
A1C.
So I heard an A1C. A fasting blood glucose. There's lots of different ways, right? Or another random one. Oh yeah, has anybody ever had the glucose tolerance test? Have you ever had, am I the only one? When you're pregnant, you have to have it. It is horrible. I had heartburn, so it's like this orange, super, super sweet, because it's a ton of glucose. So just, the good thing is we don't have to do that. I like A1C because it really tells you for the last 3 months what their blood glucose has been. Okay, so so A1C, what number would indicate diabetes? Fasting? Random? So less than or equal to, and I believe glucose tolerance is 200 as well. Like I said, it's so rarely given, but for pregnancy, to check for gestational. That's why we have the glucose tolerance test. Okay. So our A1C is 8.2. I'm gonna just talk this through because I want to get to like the case study that I found for you guys. So thinking about patho, you wouldn't want to say things like your pancreas has insulin resistance and you want to use like patient-friendly words. That's why when on your tickets to class, we'll have you say things like, how would you actually describe it? So you can say things like, your body's not able to take up sugar into your cells as it normally would. So say it in ways people can understand. And then you want to talk about nutrition, right? About increasing fiber and whole grains and exercise. It was 8.2. Okay, 3 months later, she's seen for follow-up. She's been walking twice a week. She didn't want to start medicine at first, okay? She wanted to try lifestyle modifications first. So she started walking, she stopped drinking soda, and her A1C went down to 8. So it's better, but not a great improvement, right? So the provider starts on metformin, 500 milligrams orally every day. So what would we tell her? What does metformin do? Let me just see, want to show my picture?
It's gonna lower the gluconeogenesis.
Yeah. So it's going to decrease. Can you say that in a way that?
Glucose output.
Yeah.
in the liver.
So it makes the body make less glucose. Yeah. And there's lots of ways you can say it, but yeah. And it also makes the body more sensitive to, I think about feelings, right? So more sensitive to insulin. Okay, 1 year later, she continues to work on her diet and exercise. A1C is? 6.9. So she still has diabetes, but that's considered controlled, right? So that just shows some great improvement. So diet, exercise, and medication a lot of times is a good combo.
Or just the fact that it's trending down?
No, typically, so for well-controlled is considered less than 7. For older adults, sometimes they let that number go a little higher because of the risk of hypoglycemia. If you control it too tightly, more people have died of hypoglycemia than diabetes when it gets to, because people might not feel hypoglycemia, right? So less than 8 or even 9 I've seen for older adults.
So that number specifically means control?
Okay, she goes to the hospital and her blood glucose is 200. Let's say that she's in the hospital for just like a broken leg, okay? So looking at your order sheet here, this is her dinner time. What are you gonna do for her? So do you see how there's the different types? So providers will decide what level they want to give. So that would depend on how sensitive the person is to insulin, right? They put her on moderate. So how many units is she going to get? And then how quickly is this going to, do you see they checked the Novolog? So they gave the rapid. Novolin R is regular insulin, and the provider wanted them to have that rapid insulin instead. So you need to give them that rapid acting insulin within 10 minutes of them eating the meal. Make sense? Uh-oh. An hour later, she goes, I don't feel so good. I feel kind of shaky. Because what is she maybe have? I know it's the diabetes lecture, and I kind of set this up. Like what could be happening? What would be your first action? I heard check blood glucose. I have seen in some books where they say if somebody's unconscious, like don't even check it, just give. I've always checked it because you can check it so quickly. But she's awake and she's talking, right? So you'd want to check it. Uh-oh, it's 55. What are you going to do? Look at your sheet there. We already talked about it once. She's talking to you, right? So what are you going to give her? What kind? Just kidding. Doesn't matter. I'm a fan of apple myself. So you give her some apple juice, and then how soon after are you going to recheck? Look at that, 15. Wow, we're so in sync. It's 60. She's not feeling as clammy. She's not shaking. She's like, I feel better. Because, first off, it didn't go up very much, right? But that short-acting, simple sugar is not going to last very long, right? So you're going to give more. And then when are you going to recheck it?
15 minutes.
Okay. I would have you give an S-bar to the provider. You'd also call the provider, because it could be that maybe they need to have their medicines adjusted, right? It could be that maybe she needs to be on the low dose because maybe she's more sensitive to insulin than we thought. So you would call the provider and you would give a beautiful F bar. Okay, so now I want to make sure you had some time for this. So I have this case study for you, and I'm just going to talk it through really quick. I made something for you guys. I didn't make the case study. I'm not going to say credit. I didn't make it. This is a true story of a person, because you guys like it's not even a scary one. It's a normal story. Okay, so tells the story of a person with diabetes. It gives you some physical exam findings and some lab results. Do you have a second page on there? Oh, the lab results didn't get, I'll give those to you. Can I give those to you? I had one job to make a copy. Okay, lab results. Fasting glucose, 178. Creatinine is 1.0. Normal is 0.5 to 1.4 for that. Blood urea nitrogen is 18. Normal is 7 to 30. And A1C is 8.1. Do you need those again?
Yes.
Okay. Fasting glucose is 178. Creatinine is 1.0. Blood urea nitrogen is 18. A1C is 8.1. So, this is my present. So, you're going to take the story and you're going to talk about it together, right, with your partner. And you're going to say, okay, I think these are the top 2 problems that are going on. So, either problem statements or nursing diagnoses, right? I'm not going to tell you. Let's just say I'm saying it's constipation, because that's not on there, okay? So, the signs and symptoms that go with constipation, I'm going to put in here. And then I'm going to have my nursing diagnosis. It's a way for you to learn how to cluster things, right? And then you're going to put down some nursing interventions for each of your problems. And then how you would measure it, or like what would be some good outcomes. So like a bowel movement would be an outcome. I picked the most boring examples. And then RX. What prescriptions might you expect, or what do you think might be something that would be helpful for your problem? Mine would be Senecot. Okay, so go ahead and work through that, and I want to make sure you guys have enough time to do it. So how about hold on, so work on it now, and hold on to it, and then we'll go over it together at the beginning of class on Thursday. Sound good? And I'm here if you have questions, okay?